Okay, we're recording now, Julius.
Thanks very much. Thanks very much, Sarah. Sarah always has this slight palpitation before the start of the webinar that I might not master the IT, and she's quite right to have those concerns. But it looks like it's all going swimmingly this evening. So welcome to the second Surrey and Sussex webinar about the GP contract 26-27. I will, as Sarah said, if you've got any queries or questions, please put them in the chat and I'll keep half an eye out on them and see if I can incorporate those. And obviously we did get some queries and questions on Tuesday, and I'll do my best to sort of make sure that those are reflected in this evening's presentation as well. And as Sarah said, the recording of the presentation will be available on the website probably by Monday next week. So the aim of this evening is to go through the sort of contents of the contractual webinar for next year. And I've just put a brief list there, the usual sort of things that I would cover. And then we'll talk about next steps as well. So I always start off with a sort of financial sort of package and description, and I know that there's been some sort of queries and questions about the allocation of money as well, so I will cover that as well. Okay, so this year there's been a net uplift of 416 million in the practice contract and 69 million within the PCN DES contract, and that represents a 3.6% increase. Now, there's a really important caveat to this year's figures, which is that we do not yet have, unfortunately, the DDRB recommendation for 26-27. And even when we get it, we have to wait to see what the Secretary of State thinks of it as well. We do have the Agenda for Change uplift at 3.3%, and the betting money is that the DDRB will be around 3%. So that means there'll be an additional uplift. We had hoped that that would take place before the April pay run, but that's looking less likely now. But certainly, if you recall, last year it didn't take effect until September, October. We think it'll be much earlier this year. Now that's not an insignificant sum. Last year, right. I just want to check. Can everybody hear me? Because somebody said they can't.
I can hear you, Julius, loud and clear.
Perfect. That's great. Well, then perhaps your end in terms of. So the contract last year, the DDRB uplift eventually increased the overall contract value by 122 million. The gap between the pay assumption of 2.5% and what DDRB ultimately, what's recommended by the government probably won't be as big this year, but there'll still be almost certainly an uplift in the contract value. So in terms of breaking down the individual contract sums, there's an additional 260 million into global sum. 30 million to the QOF, which is primarily related to the increase in QOF indicator numbers, but there's 5 million going in there for QOF childhood immunisation, 121 million in terms of list growth, and 11 million in terms of SFE locum reimbursement. Now, the other important things to note is that the 82 million from advice and guidance, the enhanced service for 25-26, that is being retired, and the 82 million is going into global sum. And there are 292 million being transferred out of the PCN DES capacity and access payment. Now, this has been quite a sort of controversial change. Just to clarify from one of the questions on Tuesday, that 222 million is outside the global sum uplift, but the 82 million is being incorporated into global sum. We've lost 7 million from the weight management service, which is being retired based on the changes to QOF, and that hasn't been transferred because that was actually never derived from the NHS England primary care budget. so it's lost. Now, in terms of PCN funding, the transferred funding 292 million, but there is an increase in PCN funding nonetheless. That relates to the ARRS allocation, enhanced access and the PCN leadership funding, and primarily that increases because there's a pay assumption of 2.5%, and that's been incorporated into those uplifts. So, in terms of detailed figures, global sum will rise by £5.35. That's a 4.3% increase, and a reminder that although we may get a contract overall uplift of 3.6%, because of the way that it's all worked out, the global sum increase is a higher percentage than that. Now, advice and guidance been put into the global sum. That is being excluded from the out of hours deduction. So the percentage for the out of hours deduction falls to 4.7%. Because global sum's gone up, despite that fall in the deduction, the global out of hours deduction still rises, but by 19p. And then I know this is somewhat illusory because it doesn't relate to the real value of QOF. Instead, it relates to the change in the average population. But the contractor population increase index has increased, and therefore there'll be an increase of £2.46 in the QOF point value. So, what I would have liked to be able to present in this slide was an increase in the item of service fee for immunisations. We really pushed hard for this, and also when I come to it, I'll talk about the childhood immunisation indicators in QOF. We really pushed hard for this, but they just won't budge, and therefore we were unable to secure an item of service increase. And I'm sure that many of you will have thoughts about that in terms of the potential viability of the seasonal vaccinations. Unfortunately, we can't do anything about the options with the childhood vaccinations and other vaccinations that are included within the SFE because they are actually part of our core contract now. But we did get an increase in the sickness, parental and other financial reimbursements related to leave. That will rise by 2.5% in line with the pay assumption. And we think that will rise again once we get the DDRB recommendation. And we think we've secured a sort of precedent now that the SFE reimbursements will rise each year related to the final post-DDRB figure. And as you know, with general practice funding, it's really a nightmare because you get an increase and then nothing happens for some years. Just like the DVLA fees that I wrote out about a couple of weeks ago, nothing happens. The value relative to inflation falls, and then you get a zigzag uplift again. Whereas what we really want from fee increases is a regular uplift. Now, obviously, what we really want too is an inflationary uplift, but we can't always get that. But not getting any increase at all causes the whole fee level to fall significantly. So that will rise by 2.5% plus DDRB. Please put any comments or questions you might have in the chat so I can sort of link them up to the slides I'm presenting. Now, in terms of PCN DES, the biggest change, in fact, the first real change in terms of dedicated funding within the PCN DES since its inception is the transfer of 292 million out of the capacity and access payments, and that comprises both the support payment and the improvement payment, and obviously the latter was tied to achievement in that there were targets that you had to meet to get that, and we gave separate advice on the sort of doing that towards the end of March. Now, this hasn't gone into global sum, but what it's done is to support a practice level GP reimbursement scheme. So it's ring-fenced at 292 million across England. Sadly, not 292 million across Surrey and Sussex, where it would actually have had a significant impact. And it's only for GPs. So you can only claim against GPs for this scheme, either by engaging additional GPs or funding additional sessions from current GPs. Now, I can't give you a sort of exact analysis of what this scheme is going to look like, because it's not likely to be within the 1st of April statement of financial entitlements. We have pressed NHS England really hard to get it out as soon as possible, and we hope that it'll be within the May entitlements, although claims will be allowable from the 1st of April. But I really do understand that you may be reticent about this if you haven't got the full details, and we hope that there will be sort of interim details about the sort of claims that you can make. Now, NHS England have said that they want this to be a light touch arrangement, which always makes me roll my eyes whenever NHS England say that. We have pressed them in terms of, well, what do you mean by GPs? They've come back to us and said, well, that doesn't matter about their contractual status, could be partners, could be sessional, could be locums. We've pressed them in terms of, new GPs or current GPs, including partners, working more. And again, they've said that's how they feel the scheme should work. And we pressed them about the sort of additionality issue, which they feel is not as relevant as for the ARRS scheme. And then we pressed them about what obviously colleagues have been in touch with me about as well. If you are currently paying or for a GP through the capacity and access support payments that you're getting to your PCN, will you be able to claim reimbursement via the practice reimbursement scheme? And the answer from NHS England, and obviously, we can't sort of say absolutely until we see the details, but the answer to from NHS England to that question was yes, because it would be completely perverse, even for NHS England, for you to be paying for a GP through funds that are then transferred to a different scheme, and then say, oh, well, you can't pay for a GP, you can't carry on paying for the GP through the money that's been transferred from one payment scheme to another. So the answer to the question, which I know a number of colleagues have raised with me, is yes, that should be possible. And in addition, we are expecting the salary level to rise, because as I'll come to in a moment, the salary cap on the ARRS scheme is being lifted, and we don't expect the salary cap for this scheme to be different to the ARRS scheme. No, it's not the case that, sorry, I've seen a couple of questions. Here we are. No, it's not the case that it's only practices with very high GP to patient ratios that will enable you to access this scheme. It's just that practices with very high to GP to patient ratios, the ICB, if you want to recruit through this scheme, the ICB want to have a specific discussion with you about the numbers of GPs that you have. So that's just been put in there as an additional way for NHS England to think about your workforce, but it's not a sort of gateway to access the scheme or anything like that. But NHS England, after many years of us telling them so, NHS England believe that we should have more GPs per patient. And I know that I can't see you rolling your eyes, but I know that will be what you're doing at the moment. And the ARS scheme, obviously, they decided 2 years ago to include GPs in that, and that's a recognition too that they wanted to encourage the engagement of more GPs within the general practice workforce. So stolen my thunder slightly in that the ARS scheme, I've already said to you, the salary, the claimable salary level, and obviously the proportional on cost as well. That will rise, we think, to the upper quartile salary GP pay, but we're waiting for a final confirmation on that. And obviously the salary range is awaiting the DDRB uplift as well. And the restriction on recruiting GPs within 2 years post-certification, that's been removed. So that's not an issue now at all. Anyone can be recruited through this scheme. And the way that the scheme, the ARS scheme, is allocated, now that is a huge amount of money now. It's £1.7 billion. That's up to the PCNs. So you get your allocation, which is capitation based, and then how you subdivide it amongst your core member practices, how you make decisions about who you'll claim and recruit against the scheme, that remains entirely flexible to PCNs and their core member practices. And we know from discussion across the LMC, PCNs do many different things, but we'd encourage maximum sort of autonomy and discretion within the PCN core member practices. So that's the ARS scheme. Now, we've had a lot of questions about this, and I know that the arrangements aren't going to tick everybody's boxes. What you need to do is to look at the current spend that's related to capacity and access. If you are currently spending by supporting GPs, then, as I said, you should be able to substitute for the practice-based reimbursement arrangements, and you should also, if the salary is being subsidised at the moment by PCNs, which we know for some PCNs it is, you should be able to make increased ARRS claims in relation to the salary of currently engaged GPs whom you're subsidising that salary for. Now, we are awaiting the PCN DES specification, but that's the position we believe will be taken from 27. Now, this will leave a cost pressure. We understand that, and it was a balance, and we had concerns that this money might disappear somewhere else. So, it's a difficult decision, but we hope that it will, in the same way that allowing GPs to be recruited through ARRS, we hope that this scheme will help practices recruit additional GPs. Now, you could say, well, wouldn't we have wanted it in global sum? I guess if I'd been giving this presentation 5 or 10 years ago, we would have said absolutely. But we're increasingly conscious that the Cahill formula is getting antiquated, and I'll come on to that in a bit. And therefore, there's a distorting effect when we put funding through the Cahill formula in order to put it into global sum. And therefore, practices are drifting away from the original sort of work-based proxy basis of the formula. So we have to see. In terms of the uplift to other ARS PCN roles, the entire allocation of the ARRS has been uplifted by 2.5%. It's not just the GP component. And remember, there's no restriction now. If you had an imaginary world in which you were just starting off as a PCN, you could spend your entire ARRS allocation on GPs if you wanted to. That's not a green light. The LMC doesn't want to get embroiled in your HR issues, but there's no restriction to how many GPs you recruit under the ARS scheme. The practice-based reimbursement scheme is only for GPs. There's been an uplift of 2.5%, but there will be a further uplift in the ARRS allocation, reflecting the costs of all colleagues recruited under the ARS, some of whom have agenda for change arrangements, and we know that's 3.3%. We're awaiting the DDRB final agreement before a further uplift to the ARS scheme to take into account the additional costs of Agenda for Change and any DDRB supplement on the 2.5%. So we are actually expecting the ARS allocation to rise by close to the 3.3% Agenda for Change. Not some way short, maybe marginally short, but not some way short. But I'll have the exact figures once we've got DDRB recommendation and agreement. Now, there's a few more things that PCNs are going to be asked to do. One of them is this risk stratification of patient cohorts to prioritise patients who would most benefit from continuity of care. Now, obviously, GPC England and the LMC, we really support continuity of care, but we said to NHS England, well, okay then, so you want PCNs to risk stratify to identify those who would most benefit from continuity care, although we personally think that, you know, pretty well the entire GP list would benefit from continuity of care, but they didn't explain how PCNs or member practices would be funded or have the capacity to do more continuity of care given the sort of fragmentation of care that's being provided, and like they always do when we point out something that is true, obvious and a problem, they just sort of moved on to the next discussion because take it from me, NHS England have not resolved how they are supporting general practice in a good way as yet. So they may have some good ideas, but they're not backing those up with adequate resources. In terms of PCN DES cancer requirements, there's a push for PCNs to discuss with their member practices the sort of referrals that you make and the safety netting that you have against those referrals and identifying patients. And the best way of doing all this is to contact our local Cancer Alliance colleagues who are really sort of clued up and can support practices in this way. So this is something where we really appreciate the support from the Cancer Alliance. And this one, I guess, has become really topical over the past couple of days, and I will go through this in detail. So unfortunately, again, we haven't seen the final wording, but there is going to be a requirement for PCNs to identify patients in their care home, in the care home setting, who should be offered vaccinations. Now, the PCN is not responsible for delivering those unless, of course, you have subcontracting arrangements, or they're not going to be called collaborative arrangements, but they're going to be called sort of subcontracting to other organisations, and federations might be another good example. We have seen version 2 of the guidance been sent out. Interestingly, that did not come to GPC England before it was circulated. And we've also seen a number of what I can only describe as rather sort of terse and very directive instructions to PCNs, telling them to submit information by close of play yesterday, in fact, the 11th of March. So because it was appearing all over the patch, I sent out a letter yesterday morning. There is nothing in the current enhanced service specification. There's nothing in the current DES specification which says that you are responsible for identifying where patients in care homes will get their vaccination from. But I know the ICB asked you not only to identify where this would happen, but to get in touch with local community pharmacists as an alternative place. Now, that is the Commissioner's job. We don't believe that the regulations will be written like this, and I don't think the ICB should be sending out demands like that. However, I would also say to all colleagues, I know how important the vaccination programs are. I know how important it is for all of us to act as an advocate for our patients. I know that patients expect general practice to be the source of their vaccinations, but you've got to ask yourselves, is this still an economic proposition at £10.06? Especially with the loss of the home supplement of £10 from the COVID scheme. You know, there comes a point where you are essentially subsidising the NHS. And if you want to do that for professional reasons, I'm not going to criticise anybody because, you know, acting professionally is the core of what we do. But the longer we go on subsidising a service, the less likely NHS England is to increase the fees. If on top of that, opting to do a practice-based vaccination scheme creates a liability for your PCN, then I really do feel that you know, this may become a liability rather than a sort of public health opportunity. We have spoken to NHS England, argued with NHS England that, you know, practice-based immunisation programmes are the core, or one of the cores of public health in this country, and they're absolutely mad not to support it as much as they can. We've pointed out the example in Scotland where they farmed out immunisation arrangements to non-practice organisations, and that has not led to an increase in vaccination rates. But they've been exceptionally resistant to this, and whilst I'm not directing you in any way, and of course I will really emphasise that the chartered immunisations within the core contract, so you can't not do those, but the seasonal immunisations for COVID and flu, I would really counsel everybody to have a really good think. And obviously, as soon as we have more clarity about what the regulations actually require PCNs to do, then we'll circulate that as well. Really difficult situation. Now, neighbourhoods. Now, when we went into the negotiations in October, we were expecting to have some long discussions about neighbourhoods. We were expecting to see definitely a single neighbourhood provider, SMP provider. We were expecting to see the contract. We were expecting to see some funding suggestions. In fact, we were quite anxious about what those funding suggestions might be, because obviously it's a core part of our role not to see any money that's currently invested in general practice be dissipated on something as nebulous as a neighbourhood. But the weeks went by and nothing materialised, and now we all know, and I've got a separate slide on that, now we all know that we're not going to see multi-neighbourhood provider contracts or single neighbourhood provider contracts and identified funding until at least April 2027. So how significant is this, or is this a good example of where there's a mismatch between policy expectations in one part of the NHS and you know, these contractual suggestions? And of course, the signalling here is really difficult because they wanted greater alignment, but they, in the same paragraph, said this isn't intended to signal widespread reconfiguration. I really don't know how significant this is going to be, but I think it's really important that PCNs, you know, comprise practices and colleagues who are working together. And if that's what's happening at the moment, I would not suggest that you contemplate changing it for something as nebulous as a neighbourhood at the moment. We know, of course, that PCN configurations have evolved since 2019, and also basically, you know, those configurations have evolved as a sort of reflection of working relationships. And sort of practice changes as well. So they probably don't, in some areas, really align with neighbourhoods. But you know, reconfiguring your PCNs is a good recipe for sort of a lot of stress and angst. So I don't think I just look at your neighbourhoods and say, right, this is a project for 26, 27. We are not anticipating that the ICBs, and I'll come back to ICBs in a minute, we're not anticipating that ICBs will see this as a high priority given everything else that they've got on their plate at the moment. Right, so that's everything on the core contract and PCN DES. So that's covered a substantial part of the contract. Now QOF. Now obviously we're still waiting for some of the finer details, but I can flag up that this is likely to create a additional workload. We told NHS England this, and they said, oh, well, there's another 18 QOF points, but we asked the policy leads at GPC England, and they both really advised that although obviously from a clinical perspective, the diabetic indicators and the heart failure indicators really positive, this is likely to produce work. There's also going to be some obesity related indicators as well, and in recognition of this, the weight management in heart service is being retired. Now, this is not what we wanted. Obviously, it's always a difficult balance because we're not in the sort of business of saying no to sort of clinically important issues, but we wanted the resourcing associated with this to be increased. The other issue that some colleagues have come back to me on, and is definitely a point, is that some of this is covered by existing locally commissioned services. And we do have the principle that, we can't sort of support a position in which you're paid twice for the same thing. So there are likely to be changes to the locally commissioned service. However, we have got the art of rewriting the specifications so they don't exactly map over to QOF, but they still ask you to do things for which you can be paid. That is something that we've done before, and I don't expect any initial immediate changes to the locally commissioned services because obviously ICBs, as you know, going through some substantive reorganisation, and they may not be in a position to sort of initiate significant changes in your locally commissioned service specifications at the moment. Now the other thing about QOF, so basically this again, it's so irritating. So basically what we said to NHS England was, we understand you're in a financial hole. However, if you got rid of the current QOF childhood vaccination indicators and put all that money into the vaccination item of service, that would be fiscally neutral, and it would be welcome. I think it'd be welcome that it's removed from QOF, and it'd be welcome that there's an increase in the item of service payments. Would they do that? That, I guess, is a rhetorical question, because you know that they didn't. And the other thing that we argued again really strongly for was the personalised care adjustment for parental dissent, and they would not move on that as a different policy position from NHS England. They don't want to do anything which they think would legitimise parental dissent for vaccinations. But of course, we know that that's affecting our income. Particularly challenging, it's a health inequality issue as well. And then they came along and said, well, we're not going to do the sensible thing. We're not going to agree to to personalised care adjustment, but we recognise you've got a point. So let's make this a bit more complicated. And basically, you can now be paid for this either by your achievement thresholds or by a sliding scale of improvement from the baseline, because they said, we accept your arguments that practice is a disadvantage in some areas. So if they can demonstrate an improvement from the baseline, they can be paid for that instead. And obviously, this will benefit some practices. They've modelled it and they put 5 million more into the scheme, into QOF, to pay for this. And you will be able to choose. Okay, so you can look at your outcomes either in terms of threshold or in terms of improvement from baseline, and whichever is better fiscally, you will be paid, or you can choose to be paid on that basis. We don't think this is a good solution. We don't think this is a sustainable long-term solution, but we've accepted this because at least some practices will benefit and nobody will be disadvantaged from their current position. So that's QOF. Now we have advice and guidance. Advice and guidance. So last year, you'll remember, the advice and guidance enhanced service was introduced, and I'd like to thank a lot of colleagues who've worked on this, both in primary and our specialist colleagues as well. NHS England think it's been a success, which is great. But now they've decided that they're going to get rid of the enhanced service and put all the money into global sum. They almost spent the 80 million last year, and if you've still got claims, and you should carry on making claims under the advice and guidance enhanced service until the end of March. But the money plus an uplift is being transferred in global sum and creates a £1.28 increase in your global sum value. Now, from an LMC perspective, we were always sort of fairly, how can I put it, sort of careful about this. And basically our advice was, well, there are times when you might find specialist advice helpful in terms of managing your patient, so ask for it. And the only difference from the 1st of April last year was that you'd actually be paid for that. And now you won't. But if you simply used advice and guidance as a source of additional clinical information, rather than sort of seeing it as a sort of financial income stream, then you should carry on doing exactly the same thing, which is to ask for advice only in the clinical circumstances where you would find that basically helpful. Now we know that some of the advice you got back has been very delayed, and we know that some of it was basically looked like the investigations that you get from a first outpatient appointment. So obviously, if you're hoping to look after a patient with specialist advice and you don't get it in a timely way, you need to refer that patient for the specialist opinion. And if you get back a list of things from a specialist which looks like what you would expect from a first outpatient appointment, and by that in particular I mean asking for things that you wouldn't normally interpret, investigations that sometimes you can't even access, which shows how much how much joined up thinking there is, then I would just ignore all that and say, here's the patient, thank you very much. Now obviously, one of the reasons that NHS England like advice and guidance is they think it's a mechanism for reducing the specialist waiting lists, which is a huge political hot potato. And so anything that would reduce the waiting lists, ostensibly reduce them, is seized upon. And as you know, the Secretary of State has said that they have reduced the waiting lists, but we all know that they've just gone through them and taken off people who actually shouldn't be or don't need to be on the waiting list already. So that's not really a reduction in the waiting list in terms of clinical care, but it gave them the numbers that they wanted. So instead, we're seeing the single point of access. Now, we've been really clear that these have to have locally agreed pathways. Unfortunately, in some areas, the hospitals have imposed pathways on general practice. A great example recently from Frimley, and we're not going to agree to any local pathway that doesn't allow you to refer for a specialist opinion, and instead means that all you get is advice and guidance. And we know that there are parts of the country, including Portsmouth, where some of our West Sussex colleagues refer, who are routinely getting back advice when they refer patients to for a first outpost appointment. Now, the fact that this is being framed more formally on the basis of locally agreed referral pathways is helpful to us. And also, I don't think any of us are going to sort of dismiss what might happen in a single point of access as not helpful, because obviously we refer in and it's the referrals assessed by a specialist, and the specialist says, yes, we need these investigations and we need these radiological procedures, etc. That actually is fine as long as the specialist deals with the results and communicates with the patient and organizes it all. And if they do all that themselves, that doesn't seem to me, and I think all of us would agree that, well, if they do that through an SPOA, or if they do that sitting metaphorically in an outpatient appointments, well, from our perspective, it probably doesn't matter. And if specialists look at your referral and it's so sort of classically helpful that they know automatically what procedure the patient's going to need, and they refer them on for that, and get in touch with the patient and organise the procedure and deal with the outcome, well, that's probably entirely appropriate too. So we're being a bit careful about this. I know there has been some guidance issued by other LMCs, but we're just going to wait and see how it evolves a bit. But the sort of categoric assurance from us is that we're not, on your behalf, going to agree to anything that means you can't refer for a specialist opinion. But I'm not going to say you can never sort of only refer for an outpatient appointment. What we really want, or what we really mean by that, is we want specialists to look after our patients when we know that we can't do it ourselves. And in some ways, how they organise all that, as long as it doesn't come back to us, doesn't seem, that doesn't seem the sort of nub of the problem, really. So that's where we are with advice and guidance. In terms of the question, they haven't pulled the funding technically. I think we should, that's probably not fair, because they've actually put it into your global sum. And we all know in global sum that if there are any uplifts, that goes into the, that is then uplifted. So there are advantages in going into global sum, but there are disadvantages because of the Cahill formula. So it's a really difficult balance. But in terms of 82 million, I'd rather see that in global sum than anywhere else. When you get to 300 million, the distorting effects of the Cahill formula may mean that that's not so directly beneficial. Now, everybody's waiting for me to talk about access. None of this is good news. Well, there's a couple of sort of slightly better news, but the political thrust behind this is that the politicians are obsessed with your access. They're not clinicians, and the clinicians for whom they're taking advice from are not giving them, a consensus view from general practice. They are giving them advice that perhaps politicians want to hear. So essentially, can't cap the number of requests submitted through online consultations. Well, they said, oh, you shouldn't worry about this because this is already effectively in the regulations as well. Now, one of the things that has challenged everybody is their comment about clinically urgent. And again, weasel words, they said, oh, well, you don't need to worry about that because it's only if you say it's clinically urgent that it is clinically urgent. But we all know that patients ring up and they need, or they think they need a problem solved urgently. So they think they've got an urgent problem, and it can take a while and it can be a bit disruptive to our relationship with the patient when we actually say, well, actually, it's not urgent and I'm not going to see you. So that always creates a problem. However, in terms of the monitoring of this, which I have been asked about, not the clinical sort of best way of dealing with the scenario, but in terms of monitoring, we know that ICBs are not going to be able to monitor this. Okay, and in fact, I would go so far as to suggest they probably don't even want to. But if you see patients on the day, then they are urgent. And if you don't see patients on the day, then by definition, they're not urgent because you haven't seen them on the day. Now, obviously, this is a tautology, but in terms of if you're being asked whether you see urgent patients on the day, the answer is yes, of course I do, because the patients who are seen on the day, a subsection of those are urgent. Obviously, you'll see patients on the day in other circumstances, but in terms of defining whether a patient with an urgent request is seen on the day, well, if you don't see them on the day, then it can't have been urgent. And that's the approach we're going to take to the ICB. If the ICB gets in touch with you and says, what about these urgent patients? Please get in touch with us. There's an underlying theme here that I emphasized on Tuesday, and I'm going to emphasize again. Do not ask your commissioners to define urgent or in fact anything else in the contract. Okay, if you ask your commissioners a question, then they have to answer on the basis of what NHS England tells them. Okay, and that's not a criticism, that's just the way it is. So if you want to manage your patients and look after them in the way that you think is best for their clinical care, then please don't ask the commissioners anything about how you should look after them, because they can only say what NHS England tell them. And it's much better for you to look after them without that. If you get the ICB coming along asking you sort of questions, and then we've got another slide about unwarranted variation a bit later on, please get in touch with us, because and we have very supportive ICBs. It's only when you see the sort of how can I put it, variation in ICB activity across England that you realise that we've had some really good colleagues in both Surrey and Sussex and South West London, and they're going through a really difficult time at the moment. So this is a question that's come up several times, which is that if you have a patient who's urgent and you recommend ED, then is that suitable? Now, we don't ask that question, okay? So if you have a patient who rings you up and the most clinically appropriate response is to divert them to ED, then that's the right thing to do. I'm not asking whether that patient is categorized as urgent. It's nothing to do with the regulations. It's purely your clinical response to the patient who contacts you. Okay, so let's not make our life complicated. If a patient contacts the practice and it's clear from the description of their symptoms that they need an ambulance or they need to go to ED, and that's the right clinical disposition for them, then that's what you do. I'm not calling them urgent. I'm not calling them non-urgent. I'm just saying choose the best clinical advice to your patients. Okay. And that's how I would answer that question, and that's how I'd recommend colleagues answer the question if they get any questions, although you shouldn't get any questions about that. Okay. So in terms of this question about NHS 111, most of us would not see NHS 111 as an appropriate disposition for a clinically urgent scenario. Okay, and I don't think many of us have used NHS 111 as the disposition for clinically urgent cases. So I wouldn't refer patients to 111 because they're urgent. But on the other hand, if you have patients who ring you who appear to need to be seen, and 111 might be an appropriate clinical disposition in terms of the advice or care that they want, then you're not defining those patients as urgent, okay? Because remember, this slide defines who's urgent. But they may be appropriately diverted to NHS 111. I know some of you are thinking, Julius, write a book about semantics. And this, I'm not disguising the fact that these access changes are going to create a workload for us. And some of NHS England's clinicians think our job is to be the community version of ED. And that's not what I went into general practice for. And I'm willing to place a bet that of the 100 people on this webinar, the vast majority of you, if you're GPs, did not go into general practice to be a community ED. Okay, we think that the sort of value of general practice is continuity of care, is long-term condition management. And yes, we do see patients who need to be seen on the day, but that's not, our core work. But unfortunately, NHS England is caught in this trap between the clinical advice that they receive and the political pressures that are exerted. So it's a difficult one because I know these access requirements and online requirements are producing a workload, and we are changing the way we run our practices to reflect that. And we are almost certainly going to be generating our own waiting lists, because you cannot expand capacity indefinitely. And so once we start to have waiting lists and the hospitals start to have waiting lists, we can sort of pretty comprehensively tell whichever person is the Secretary of State in the future that their policy has failed. CQC have always looked at your access, so there's nothing new about what CQC are going to do in terms of these regulations. So CQC have always seen access as part of responsive healthcare, and it's not going to make them more or less likely to look at the access that you're providing. And finally, patients can't be asked to call back on another day. Now, again, don't make life more complicated than it is. So one of the questions I was asked is, well, can I ask them to call back at 2 p.m? Now, obviously, that is not another day. It's the same day. So yes, you can. And remember, appropriate response. Now, there was a lot of criticism of the way that the regulations were worded, and that is being changed so that the implication that you stay until 11:59 the same day to finish off patients' requests, well, that is being taken out of the regulations and is going to be explicitly next working day, core hour period, not next day. Not same day. So we have got that adjusted, because we did say to them, well, you can't have a contract that by implication means that colleagues are working outside core hours. Now, we know you are working outside core hours, but the contract it can't say that you do. Okay. So that's where we are with access. And the other thing that we've got is you putting your opening times. Please don't put anything complicated about your waiting times, opening times in any of your communications to patients. Keep it simple. Don't sort of imply that some services are available and some services aren't. That doesn't apply to branch surgeries. Your branch surgery may have different opening hours or access hours, as long as patients who would normally use your branch surgery can access your main surgery if they need to. Then the branch surgery may not have the same opening hours as your main surgery. Pharmacy. Now then, obviously, appreciate everything that our community pharmacy colleagues are doing. NHS England appreciates it too, and they've realised that there isn't necessarily a reliable conduit for information. So you now have to have an email address, because they've realised that GP Connect isn't always there, or the pharmacy might be doing things that don't link up to GP Connect. It doesn't need to be a new email. You can just use a monitored email for this purpose. Now, they also wanted us to sort of confirm, this is all part of the patient choice agenda, that if we prescribe something new, we would say, well, where's it going? But I don't know about you, but if I see a patient and I'm prescribing something new, I usually say, do you want this sent to your usual pharmacy? And then they usually say yes, and you have covered that part of the regulation. So you don't have to do anything. If you ask that question as sort of routine part of the consultation, you don't have to do anything new or sort of special for that. But what they also want to do is, and I know colleagues will be aware of prescription direction, so you're not supposed to tell the patient where to go and get their prescription dispensed. You're supposed to say, here's the prescription, or where would you like me to send this prescription, and then the patient can choose. Now, as pharmacies have started to do more than just dispense prescriptions, they are concerned that some practice websites offer access to pharmacy services, but they only offer it to a specific sort of number of pharmacists, or in some cases just one. And this has been raised with the LMC by the local pharmaceutical committee, and in fact not special to Surrey and Sussex. It was raised by different areas, and obviously Community Pharmacy England, which is the national negotiating body for community pharmacists, they flagged it up as well. So we're working with them to produce joint guidance that covers both dispensing and also patient access to pharmacy services, which aren't just dispensing. Essentially, if you've got a sort of link or signposting to pharmacy services, you need to make sure that it doesn't sort of tell patients to go to one specific place. It's perfectly okay to list, neighbourhood pharmacies in order of distance. That's no problem, or even in terms of your adjacent towns if you're a rural practice, but not to divert patients to one individual pharmacy. A few more sort of fairly, I suspect, not consequential contractual changes. The commissioners have the power to object to subcontracting arrangements. They have more power for GMS contracts than PMS contracts, and they're just changing that so that it's uniform. Reporting for online and video, a huge part of your work, I'm sure. Consultations, reporting analogous to cloud-based telephony, unwarranted variation. So NHS England don't understand that the services that you provide are predicated on your demographic list. And also, we're not robots. We all have different ways of consulting. We all have different ways of organising our practice. If the ICB gets in touch with you and says, oh, there's some unwarranted variation here, please get in touch with us. We will, I'm sure that what appears to be unwarranted is entirely warranted. It just needs a bit of rephrasing. And actually, the recent efforts by our ICBs in the southeast to identify some unwarranted variation, the feedback we've had from GPs in Surrey and Sussex have been that the ICB has been pretty supportive. But as you can guess, this is an NHS England initiative. Nothing in the regulations describes what support the ICB will offer. We did ask NHS England that as well, but I always avoid answering those questions. Please don't get anxious about this. Please don't feel this is performance management. Please get in touch with us if the ICB identifies what they think is unwarranted variation, and then we'll help you know your practices. You know, we can just help with a few questions perhaps that will assist you in demonstrating that this is not unwarranted at all. Your staff now will be invited to participate in the whole staff survey, NHS staff survey. I have seen some criticism of this. I don't know. Employers will get some detailed information out of this. I guess as employers, it's important for us to understand what our staff think. This is a mechanism of doing that. It's hard to say that, you know, getting information about what our staff think about where they're working and their sort of environment in which they're sort of managed and asked to do tasks. It's hard for us to say, well, that's information we don't want to know, or information that we you know, don't need to hear. Now, NHS England do listen to what's happening on the ground. As you know, the LMC supported many colleagues in not data sharing with the local lung cancer screening programs, not because the programs weren't good. The lung screening program, obviously, you know, it's really helpful to identify lung cancer at an early stage, but we weren't happy that the workload that was being generated by the screening programs was being properly managed by the screening program. I mean, some of us think that the lung cancer screening program is an excellent screening program for cardiac calcification and emphysema, and then you identify some lung cancers as well. But we wanted them to look after and prescribe for the incidental findings associated with the program. And NHS England noticed this and are therefore changing the regulations to mean that we have to share that data, and that unfortunately takes away a significant lever for us in terms of how we can manage workload that's created by others. The online registration, you now have to use that for everybody. If you still use paper registration, you have to transfer that into the online practice. Now, there's an interesting part of the contractual discussions this year. Some of you will know that there's an increasing gap between the population as measured by who's registered with a GP and the actual population of the country. There's a lot more people, you know, there are more people registered with a GP than there are in England, which is an interesting proposition. NHS England know about this, and they've been developing pilots in which they try and identify patients who don't use NHS services, not GP services, other NHS services, and use that as a proxy for saying they're no longer in the country. And that's pretty reliable, but it does miss out some cohorts of patients. And we said, well, this is not justification for removing the 3-month rule, and it's got a health inequality implication to it. And eventually they withdrew that, and they're just going to work on the pilot. So I think that will come back, but it's not part of this year's contract. RSV extended under the JCVI advice, as usual. The government's, you know, NHS England, the government, very good at following JCVI guidance. Now then, neighbourhoods. There you are. You can build your own neighbourhood. So the question there is yes, you can still provide paper registration forms, but you have to transfer that now onto an online registration process. Yeah, so it's all from your perspective as a practice, it's all online. But if you've got patients who want to fill in a paper form, then that's absolutely fine, but you will have to transfer that information over. Now there's a neighbourhood, looks like a nice place. We have some information which I flagged up earlier about neighbourhoods, didn't appear in the contract. The multi-neighbourhood provider can be an annex to the NHS standard contract, but that's a bit worrying because we know that trusts hold NHS standard contracts. It's being put out to public consultation during the summer, which tends to be a step that governments adopt when they're not sure what to do. And we don't think this will be implemented until April next year. Now, the problem with this is that a lot of people have spent quite a lot of time unfunded and, you know, out of the sort of hope that this will benefit patient services and care in trying to work with neighbourhoods and create sort of working relationships within neighbourhoods. All of that is completely unfunded. We absolutely understand, you know, why professionally you might want to do that, but everybody seems to have been left in limbo, and all the sort of I hesitate to use the word excitement, but all the enthusiasm perhaps for neighbourhoods that we saw in the summer and autumn of last year all seems to have dissipated. And I've been to a few neighbourhood meetings, and it's obvious that there's a sort of there are problems that could be solved by better working across neighbourhoods, but all the meetings I've been to have started out with, one, there's no money, and two, there's a sort of policy vacuum from NHS England in terms of what do we actually do. So I do appreciate some colleagues must be completely cynical about this. Some colleagues really do think that this is something that could benefit, but I really counsel colleagues at a time when general practice is under a lot of pressure, and your practices must be under a lot of pressure. I really wonder whether this is something unfunded that you should work on at the moment. So that's kind of the same message as I was giving about PCN reconfiguration. Of course, it is always up to you, but maybe this isn't the priority for 2026 that we sort of thought it was going to be last year. Now then, so obviously GPC England met, we looked at this contract and we said this is totally unfunded, totally inadequate funding. It doesn't address many of the issues that we raised. It is not a solution to general practice for 2026. So we rejected it, and then we put it out for a referendum, which is available to BMA members. Okay, so if you're not a BMA member, you can join before the 19th of March and you can vote. The referendum closes midday 25th of March. We GPC recommend that you vote no, but obviously if you think what the last 34 slides have described is a solution to your problems in general practice, then you can vote yes, but I recommend you seek psychiatric help. On the 26th of March, we'll meet again, knowing what the referendum result is, and we will be recommending next steps in terms of collective action. Now, this presentation doesn't go on to collective action, but I guess we've had some learning from the feedback we had last time. One feedback was that the menu was too complicated, and therefore, obviously, we wanted the menu because different places are in different situations. Some people were paid for shared care, some people weren't. So, we didn't want people to just withdraw even if they were paid, unless it wasn't adequate. So it's likely that there'll be a much more limited range of collective action recommendations. And it's also likely, with something we've learned from the residents, is that if you do one thing and then do another thing a bit later, then that tends to gain more traction, because colleagues see everybody thinking about doing the first thing, feel more confident about doing it, and then feel empowered to take on the next thing. So we think it will be a sequential set of suggestions, but it won't be something that breaches your contract. If we are going to suggest steps that breach your contract, that is industrial action, and that will require a ballot of contract holders. So that's the position in terms of next steps. I urge colleagues to vote in the referendum if they're eligible to do so. Please, please send a message to government, because one of the things the government says to us all the time is, oh, you're not representative of general practice. We know everybody's, secretly very happy, and we think, where are they consulting? So if you're not happy and you don't feel that this contract is a solution, please vote no. Just wanted to flag up Surrey and Sussex Secretariat for you, and also a reminder about the LMC buying group. A lot of information on our website. We'd really encourage you to think about, are there sort of procurement options for your practice that you can do through the buying group, which is supported by a large number of LMCs across England. So that is my presentation. Thank you very much on a Thursday evening for bearing with me. I've seen a few more questions, and I think I did manage to incorporate some of the answers from Tuesday. I agree. Yes, we'll be sharing these slides, and a recording of this webinar will go on the website, and also the LMC will be sending out sort of specific advice on some aspects of the contract. So we've sent advice out already in terms of the ARRS scheme. Once I know what the practice reimbursement scheme is like, I'll sort of circulate that as well. And we have an advice and guidance letter almost ready to go. So yeah, definitely, and there will be more to come. And obviously, once I know the full financial details, that will be circulated as well. I mean, I have huge sympathy for GDPR purposes. I have been told not to name people in the chat, but it seems very natural to sort of mention your name. And I have huge sympathy with the comment that has been put in the chat about, well, if we don't participate and engage with neighbourhoods, then it will be taken away. And I absolutely understand that view. But on the other hand, I think perhaps I'm sort of framing the conversation I've had about neighbourhoods as, well, will anything happen this year? Because if it's not underpinned by funding and it's not underpinned by sort of government contractual mechanisms, then, will it just turn into a discussion? And if you want to have this unpaid discussion, that's fine. I think just knowing that we're there might be enough for the moment. But I respect colleagues who feel differently about that. But obviously from an LMC perspective, we do sort of very much focus on the resources that GPs are given for the work that they're being asked to do. And in that context, perhaps you can see why I've given that sort of perspective. Right, and thank you very much for the additional comments here. The Opal status reporting tool, we want that to be extended to cover general practice, so it recognises your capacity issues, just as it does for other service providers within the NHS. General practice was omitted from the national Opal system. And we think that's because they know that we could legitimately say that our demand exceeds our capacity, pretty well every week, and they don't want to hear that. Okay, so but we are working really closely with the ICB to ensure that a mechanism for OPAL reporting to affect the DOS is the Directory of Services is available to colleagues. I'm just reading the last post. I'm appalled at the weakness of the LMC position on this and the ineffectuality of the leadership. What is the point of all of this? Well, I think I don't think I know you individually, but I think many colleagues across Surrey and Sussex have had significant support from their LMC, and the LMC doesn't negotiate national policy and doesn't negotiate the national contract. Thank you very much for that comment. If you're talking about GPC England, then I think you've got a point, but remember, the LMC doesn't just accept the national contract. We have no status or role in terms of what happens nationally. So thank you for that comment. That may be that your criticisms are directed at GPC England instead of the LMC. Right. So I'm going to finish there. We did frame it as an hour and a half, but I have absolutely no desire to keep you from your evening unnecessarily. Thank you very much for everyone who's joined. I hope that was helpful, that was informative, and obviously please do stay in touch with us if you have any sort of queries, and we will batch up this and try and send out updates in relation to the individual issues. I mean, you're sidetracking me with another question here. Will the ICB have capacity? The ICB will not have the capacity that it's had now, and it won't be responsible for some of the things that it's currently able to support. This is a real challenge for everyone, and the LMC in particular, because we work really closely with our colleagues at the ICB, and we don't know what the new landscape is going to look like from an ICB perspective. But yes, you are going to say, oh well, there we are, ICB. It was GPC England. Right. So have a great evening. Thanks very much. I hope everyone gained something from that. And look forward to future. Look forward to the future, because there are some things in this contract that are going to help some of us, and that's an important sort of consideration to take in as well. Okay, cheers everyone. I will switch